The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome. We are gathered here for the next episode of TMD Demystified live stream. I am Tony Urbanek, and it is Saturday noon. Today, the topic of discussion is TMD and neck pain, temporomandibular joint disorder and neck pain. For any newcomers, this is your opportunity to ask questions about this big problem, better known as TMJ. Everyone calls it temporomandibular joint. Interesting phenomenon. That's the way it's been for 70 years. I guess the public and the doctors can't get over the fact that we have two TMJs, temporomandibular joints, similar to going to the orthopedic surgeon and announcing you have knees. That demonstrates the confusion that has been out there and continues to be out there for 70 years about this problem. I may repeat, if I have time, I'll repeat a little story that comes to mind at the end. I hope I have time. If not, we'll do it some other time, about going back to my early dental education and the general knowledge about TMD, temporomandibular joint disorder, TMJ, at that time when I was an early dentist in training. However, more than 50 years later, here we are, and I have been confronting this problem in my career for the greater part of 50 years, both surgically and non-surgically. Again, for any newcomers, I'm an oral and maxillofacial surgeon, boarded in oral and maxillofacial surgery, trained in both dentistry and medicine and academics, and have been in private practice for over 50 years in Nashville, Franklin, and Brentwood, Tennessee. Today's topic is, I think, very worthwhile to open for discussion or questions or comments. This is your opportunity to make comments if you'd like. I'll be watching any available people who would like to do that and answer your questions as best I can, but directly. Be cautious. If you have a criticism, make sure that you bring your science with you to discuss whatever point of view you'd like to make. But first, define your terms. So neck pain is the second most common symptom in the disparate list of symptoms for temporomandibular joint disorder. Again, it's a single disorder. The TMD gurus, guru being defined as doctors who want to use voodoo and odd treatments at best just to treat symptoms, like to make it multiple diseases, but it is only one disease. The disease is chronic inflammation within the temporomandibular joint. When I explain this to patients, which I continue to do, I still see people one day a week, patients one day a week. We have a very large practice here in Brentwood, Tennessee, that sees people from all over Middle Tennessee. And I explain to them that it is only a single disease and that we're not treating symptoms, we're treating the cause. If you can make the cause go away, you don't have to treat symptoms, because symptoms go away, symptoms don't appear. It's that simple. And patients continually look at me and look to me when I explain that to them, and they go, that makes sense. Well, it does make sense. Of course, it makes sense. I can't get over the fact that we still have TMD gurus that are trying to treat symptoms. In any case, neck pain is the second most common symptom of TMD, and pretty much anyone who sees these patients will agree with that, because we know that the usual and customary, well-known, well-established, well-agreed-upon symptoms of TMD include frequent and/or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, that's that fullness in the ears like you got your ear full of water, dizziness/vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are the most common symptoms. Those are the symptoms that are well established. A couple episodes ago, I described exactly how you can arrive at arm, hand, finger tingling and numbness caused by inflammation in the joint. It's anatomical, physiological. There's nothing unscientific about it. In fact, it is simple science. If you know enough about cell biology and anatomy, of which I am also trained, I have a degree in cell biology and anatomy besides a medical and dental degree, it is easy to understand. Again, I can't get over why it took so long to bring this information to the forefront to my dental colleagues, to my medical colleagues, and through them to the patients. The patients certainly don't know anything about it. They're not supposed to know anything about it. They're not trained in the basic sciences, although my dental colleagues should be and are trained. Any dental school, any dentist goes through a substantial training in the basic sciences, anatomy, physiology, maybe not cell biology so heavily, but they get some information on cell biology, certainly gross anatomy, emphasized on gross anatomy on the head and neck. But yet, we still have the majority, literally 50% of the dentists, prescribing a night guard for the treatment of TMD. It takes my breath away when I think about all of the patients, the millions of primarily women who have this disease and are getting a night guard and told that that is going to treat their disease. A night guard is a device that goes over the surfaces of the teeth to protect the teeth. That's what it is. Does a great job. If you want to protect the teeth, you can make a device that goes over the surfaces of the teeth. That's a night guard, and it does a great job of protecting the teeth. It doesn't do anything to protect or help in TMD. In fact, most people who come in to see me with sometimes a paper bag full of several of these night guards made by several different dentists say the night guards make it worse. Well, that also makes sense because it just gives you something else to chew on, to clench on, to grind on if you have bruxism. Again, bruxism being only one of the three causes of damage to the temporomandibular joint, but bruxism damages teeth. So wearing a night guard so your teeth do not get damaged is a good idea. Does it treat TMD, the actual problem, which is inflammation in the joint? No. It frequently makes it worse. And that is a fact. But the topic of today is neck pain. How in the heck can you get neck pain from inflammation within this temporomandibular joint? Well, anatomically, physiologically, cell biology-wise, that's easily to understand. So nowadays we have a tool, a wonderful tool. You have to know the tool a little bit, know where worthwhile and what you can do with it and where you need to be careful, what you ask it and how to monitor it. But it's an excellent tool because it's very neutral in its use and its establishment. It just talks about facts. It won't talk about theories and what could be. It just brings out the facts. So I asked AI, I just used Chat GPT, one of the most common AI platforms, to create a diagram that shows how inflammation works through the autonomic nervous system to create neck pain. Again, if you are a physiologist, anatomist, cell biologist, this is all going to make perfect sense. But for those of you who are not, and I hope that this channel, this live stream is directed primarily to patients, not my fellow dentists and physicians. It's directed to patients, giving them the opportunity to ask questions and get accurate information regarding this problem. So I'd like to share my screen about this and go through the steps. Now, if you can't read it, I'll leave it here while I discuss it. But and let me see if I can enlarge it just maybe a little bit. Let me see what we can do here. Well, didn't want to do that. Yeah, so maybe you can read this along with me or just listen to me. For those who don't have the video, I think this is important. So this is how chronic TMJ inflammation causes neck pain. It's the same autonomic reflex pathway that causes headaches and also causes neck pain. So you get first of all, you get chronic inflammation within the temporomandibular joint. As I said, there are three causes to damage, three categories, three routes to damage the temporomandibular joint. The only three routes that I know of. The first one, and admittedly is the most common, is bruxism. Bruxism is clenching or grinding, either day or night. You don't have to make noise with your teeth, you can just clench. But if you clench or grind, night or day, enough, it will damage, overload the joint, at which point you develop synovitis, capsulitis, or internal arrangement. Internal arrangement is the motion or displacement of the little disc, the meniscus within the joint, and it irritates the nociceptors within the temporomandibular joint. Actually, the pain receptors, nociceptors in the temporomandibular joint, which really are contained in the coverings of the bony structures in and around the temporomandibular joint, are called nociceptors. Those nociceptors then, step two, they're afferent sympathetic stimulation, afferent fibers that go toward the brainstem, toward the brain. The nociceptor input travels via trigeminal afferents, trigeminal nerve afferents, and associated pathways to the brain stem. In the brain stem, and I'm not going to enlarge the brain stem for this particular episode, but the brain stem has an area called the reticular formation, where all the nuclei of the cranial nerves, the 12 cranial nerves, the nuclei, the beginning portion of the nerve fibers are called nuclei, are contained in the reticular formation in the brainstem, and they're very close together to the point where information arriving in the reticular formation can travel between the nuclei and get confused as to where the outflow can and should be, which can create other symptoms. But today we're just talking about neck pain. So the brain stem gets the afferent fibers arriving there, the autonomic centers of the brain stem. Goes into step 3. Step 3 is the brainstem sends efferent fibers, meaning away from the brain, to the neck muscles and tells the neck muscles to tighten up, to constrict. Why is it doing this? Because it's trying to hold the jaw still. The first fibers that cause headache will come out and be directed to the muscles of mastication, the muscles that move the jaw, which have origins and insertions in multiple places of the face, the head, and that's why headache is the most common symptom of TMD is headache. The second most common symptom is neck pain, but it's the same phenomenon. The brain, through the autonomic nervous system, sympathetic portion, is sending signals out now to the muscles that hold the whole head still or move the head around to hold everything tight still in an attempt not to move this joint. Step 4, the stimulation of the periosteal nociceptors, that is the periosteum where the muscles are attached at their origin insertion, get these signals to tighten up, and the strap muscles, or better known as scalene muscles, are attached to the bone, and they stimulate the nociceptors, and this causes pain. The nociceptors then report back to the brain, it's painful. And that is why neck pain is the second most common symptom of TMD. The second most common symptom of TMD. So that very simply explains why it's important to treat the cause, not the symptoms. You can dry needle the neck all you want, and every 3 weeks you'll have to do it again. Or you can Botox any one particular area that is hurting, and after that muscle goes through the 2 or 3 months of paralysis that Botox creates, then you have to do it again. I mean, I have patients that swear, I have a patient that swore she spent $200,000 on Botox over 10 years. I recently had one that told me I think it was $3,000, sitting in my chair with the same symptoms that she started out with after multiple thousands of dollars of Botox treatment, which is very best, treats symptoms only and doesn't treat any other symptom than paralyzing the muscle that's tight. It's not going to treat anything about the non-painful symptoms, tinnitus, subjective hearing loss, and vertigo. If you say, doctor, I had one patient this week tell me that her PCP is injecting Botox for TMD. I was stunned. Everybody wants to get in the act because Botox has a lot of money to advertise this. And by the way, Botox is not approved by the FDA to use on temporomandibular joint disorder. You have to use it off-label, and then if you put your Botox in and paralyze one of the facial nerves to cause facial paralysis, you're on your own because you have no authority to do it as approved by the FDA. Interesting phenomenon is going on in 2026. So that is the explanation, the pathophysiology, the literal science behind how neck pain is the second most common symptom of TMD, single disorder, chronic inflammation in the joint. But today I decided to actually give extra points and talk about a couple of patients that I thought apply similarly to this. And that is, let me get back on camera here. I had, over the past, it's a couple years, I've had 2 separate patients give me the same story, which is very interesting. I finally decided to track it down a little bit. And the story was this. They had come in to see me. One was a female, one was a male. They arrived about 6 months apart. but gave me a very similar topic or story when we talked about their other symptoms. They both told me that they had an episode where they had so much chest pain that they thought they were having a heart attack, myocardial infarction, and that they went to the emergency room, the emergency department, immediately, like you should. If you think you have chest pain, you need to go to the emergency room. And they went to the emergency department and had the usual workup for myocardial infarction. We're told that they did not have, they were not having, and they did not have a heart attack, but did not have any other explanation of why they had such severe chest pain. Right here. Now, it took some time for them to cycle through all of the other doctors that they had seen that misdiagnosed this problem, but both of those patients came in to see me and had easily diagnosable temporomandibular joint disorder, easily diagnosed by putting pressure on the temporomandibular joint from the open to the closed position. Push on the joint from the open, put your fingers in the depression of the glenoid fossa, push hard, bite quickly. If it hurts, the joint's inflamed. If the joint's inflamed, you have TMD, chronic inflammation within the temporomandibular joint. Well, they had chronic inflammation plus many of the other symptoms besides chest pain. I don't remember exactly how many, but they had a smattering of all of the other symptoms, headache, earache, jaw pain, etc. So I queried again AI to help me out here and to use the scientific data, not created by me or AI, just going back to the anatomy, cell biology of how chronic inflammation within the temporomandibular joint can create a feeling that you have so much chest pain that you need to go to the emergency department. And in no way do I want to be interpreted as saying, if you think, that if you have chest pain, you need to think immediately about TMD. Oh, just the opposite. If you are having chest pain to the point that it is bringing to your mind you must be having a heart attack, that is exactly where you need to go. Find the nearest hospital and emergency department and get there any way you can as fast as possible. But let me share this, if I might. The diagram that was created by AI for us. It explains how TMJ inflammation can refer pain or create pain in the chest through the autonomic nervous system sympathetic portion, through the brachial plexus, the pectoral pain pathway. First, number one, I'm going to read these, but you can read them for yourself if you'd like. Chronic inflammation in the temporomandibular joint. Inflammation of the TMJ activates the nociceptors. Again, the same mechanism, the exact same mechanism that I discussed about neck pain. It triggers the autonomic nervous system sympathetic portion. Pain signals travel through the trigeminal nerves to the trigeminal nucleus, which activate the sympathetic outflow of the brainstem. Again, in the area of the brainstem of the reticular system. The sympathetic outflow then comes out the brachial plexus. Step 4 stimulates the brachial plexus, primarily C5 through T1. And then number 5, step 5, signals the pectoralis major and minor muscles, which are the big muscles right here, to tighten up, pull on the bone, and create pain. This stimulates the nociceptors where the muscles attach to the bone, which creates a deep aching pain. Sometimes can be interpreted as crushing. That's the kind of pain that you expect from having a myocardial infarction, an MI. And the result, the brain interprets it as severe pain, and you think you're having a heart attack. But you're not. I've had 2 cases of this. Now, that doesn't prove anything at all. It just goes to show you, though, that the mechanism is there that can create pain severe enough that sends you to the emergency department. Of course, I have had hundreds of people report to the emergency department with headache so severe they can't stand it anymore, and they go to the emergency department. Of course, the emergency room does not think about TMD when they think about headaches. They think about brain tumors, they think about strokes, they get a MRI, $2,000 or $3,000 there. You walk out of the emergency department with information from the emergency room staff and doctor. They have no idea why you're having such severe headaches, but they don't think about pushing on the joints. And that happens all the time. So it is very common for patients and doctors to misdiagnose this problem. And it's not funny because millions of patients, primarily women, 90% females, 10% males, have temporomandibular joint disorder. Half the dentists in the country make a night guard, tell them it's their treatment. The other 49.94% do nothing. They say, I don't treat TMD, it's too complicated. I don't know anything about it. Well, it's my job to educate the dentists so that they know something about it. That's my job. That's why I'm here. But the live streams are primarily for patients. The problem, by the way, is primarily female because estrogen exacerbates inflammation. That's why it's a female problem in the literature for 70 years. Again, if the orthopedic surgeons had been left to treat this joint rather than give it away to the dentist, this problem would have been treated correctly one way or another 50 years ago, because the easiest way to treat inflammation in the joint is to unload the joint. That's why you have crutches. That's why you have slings for tennis elbow. By the way, tennis elbow and TMD are the same disease. They are similar. They are identical in pathophysiology. If the orthopedic surgeons who treat tennis elbow and knee problems, that use crutches for knees and slings for tennis elbow, had been left to treat the TMJ, they would already figure it out. The easiest way is to figure out a way to rest the temporomandibular joint, and that's what I did, using a device that unloads the posterior teeth according to protocol long enough to make the inflammation in the joint go away. When you make the inflammation in the joint go away, all the symptoms go away. It is this simple device that fits in the roof of your mouth, that only the front teeth touch, that you can speak with. The issue is there are other things out there that you can put in your mouth that separate the posterior teeth. You just can't speak with them in your mouth. You can't wear them 24/7, and it is extremely important to start out 24/7 to make the inflammation go away. If you put it in any old time, or you put it in just when it hurts, you're not going to make any progress. You have to understand the disease. You have to understand how to treat it consistently with a proper device. If you are a doctor and want to know more about this device, you can go to www.urbanektmj.com. If you're a patient and you want to find a provider who can provide this and you're not from Middle Tennessee, you can go to www.urbanektmj.com and find out where the providers are that are closest to you. We now have providers in 20 states who can provide this service. But I'd like to finish this up with a little brief dissertation about the difference between treatment in 2026 and the treatment that was going on in 1972 when I was a junior in dental school. As I've already discussed, we have 99 and 44, 100% of dentists either make a night guard or don't want anything to do with treating TMD because they think it's complicated, which it's not. And then there's the 1/2 of 1% or less that are TMD gurus that want to do things that border on voodoo and smoke and mirrors, and just at very best try to treat symptoms, and at very best only temporarily. But I wanted to distinguish. I had a little story when I was a junior in dental school. We had a short course called dental medicine. That's what they called it in Indiana, where I went to dental school. And so there were several, probably about 6 of my fellow students and I went into the clinic on a particular day to visit with the dental medicine clinic doctor, who was a dentist. I did not know what dental medicine really meant at the time. Now that's a whole topic, how dentistry and medicine should be coalesced, and that's a whole other topic. The problem with dentistry is they're focused on operating on teeth when they should be knowledgeable about this whole mechanism of the maxillofacial region. But anyway, dental medicine back then, 1972, as I learned, was really focused on just one disease, which is now called TMD, which back then was called TMJ, as it is almost exclusively today. TMJ, TMJ. So the doctor had about 3 different patients scheduled for that clinic morning. Looking backward through the retrospective scope, I can easily see that each of these patients, when they gave their history, had symptoms of TMD, and they expressed the different symptoms in their own words. And then the dentist did a little physical examination of the oral structures and then announced to the patient that their diagnosis was TMJ. And then he immediately told them that they needed one of these to treat their TMJ problems, night guard. And I was a student. I was soaking all this up. This is interesting. Well, so, and the other 5 or 6 students in the room had a few questions. But I had one burning question that I needed an answer. So after, not in front of the patients, but after the last patient left with the diagnosis of TMJ, being told that they would be made a night guard to treat their TMJ, just as we were ready to file out, because I hated asking questions, I had to be really thoughtful to ask a question. And I said, "Sir, Dr. William Smith, how does a night guard treat jaw joint problems?" And he went through a litany of words and sentences that made no sense to me. And they weren't connected to basic science, physiology. It was a series, basically, it was word salad. And I didn't question him after that. I just knew that he didn't know how a night guard treated TMD. Now, this was 1972. I was a junior in dental school. I did not know at that point that I was going to spend a great part of my 50-some year career treating TMD surgically for the first 36 years, and for the past 16 years treating it non-surgically. I did not know that at the time. I did not know that TMD was going to make such a large impact on my career. But at that time, when I listened to word salad, I knew for sure he did not know anything about temporomandibular joint disorder and how to treat it. We could diagnose it. We knew it had something to do with this joint. But all this knowledge was actually back in the late 50s, 60s, 70s, 80s. All this knowledge was in the scientific literature, well described and well understood by orthopedic surgeons, but not understood by dentists. To this very day, and I'll quote it again, 50% of the dentists in 2026, and this date is August the 1st, 2026, 50% of the dentists continue to make a night guard and give it to the patient and tell them that it's their treatment, and 49.99% don't want anything to do with this joint because they're taught in dental school that it's a complicated joint. There is no good solution. And the fact is that the dental establishment, the dental schools, don't understand the disease, which I just took 35 minutes of your time to actually show you how, through the usual and customary autonomic nervous system route, chronic inflammation can create two major symptoms, neck pain and shoulder pain. Actually, most of the complaints are up here, but these two patients who had severe pain of the pectoralis major and minor muscle end up in the emergency room. Interesting phenomenon, but easily explained if you understand the basic sciences. Easily explained if you understand the basic sciences. So I guess you must establish, or you must come to the conclusion then, unfortunately, that for the most part, dentists don't understand the basic sciences. It's my job to teach this. This is now my responsibility because I know this. I can bring it to the attention of the public and the professions. It's my responsibility to do this, and that is why I do the live stream. That is why I do a podcast once a week, which can also be found on YouTube, seen on Dental Town, and I write a blog on this topic every week. I'm gone past my usual 30 minutes. At this point, I see no questions, but I stimulate any listeners to come back and question me at any time, make comments, and certainly I'm open to criticism. I have no problem with that. Until next time, I am Tony Urbanek, and this is TMD Demystified live stream.